going to go ahead and introduce our moderator for this webinar. So Cruz Chan is the clinical manager for the Healing for Asians program at Richmond Area Multi-Services, or RAMS, and she's also a trainer for the Lotus project. And as a clinical manager, Cruz develops and manages the RAMS Healing for Asians program, which provides trauma-informed mental health services to limited English-speaking Asian victims of crime. And Cruz is also a licensed marriage and family therapist, as well as a registered drama therapist. And so I'll go ahead and pass it to Cruz to introduce the speakers for today.
Thank you, Ellen. And welcome again to our Domestic Violence Among Asian American and Asian Immigrant Communities webinar series. We have finished our first webinar related to background and impacts on children and youth on December 10, 2024. So for those who missed our first webinar, we have uploaded the recording and also the slides on our Lotus project website. So please feel free to check it out. Today is our second webinar of the series. We will explore clinical implications and interventions of domestic violence among Asian American and Asian immigrant children and families. This is a 1.5-hour webinar without intermission. We will have two 30-minute presentations by 3 speakers, and there will be 10 minutes of Q&A after every presentation. So during the presentation, please feel free to type your questions in the Q&A chat box that is in the bottom of the screen. And your questions will be asked by me after each presentation. Okay, without further ado, please allow me to introduce our first speaker, Dr. Hyunkag, who is an associate professor in the School of Social Work at Michigan State University. His research has focused on intimate partner violence, IPV, survivors' help seeking, perception of IPV, interpersonal and socio-cultural factors for help seeking, and the process of selecting a source of help. Please join me. Welcome, Dr. Cho.
Thank you. A wonderful introduction, Cruz. Again, I am Hyunkag Cho. I'm an associate professor at Michigan State University in School of Social Work. I'm also directing PhD program in my school. So I'm very glad to have all of you join this great webinar on this important topic. So let me just share my screen for my part of presentation. So I believe all of you see my screen where my mouse cursor moving around. So what I'm going to share with you is mostly about research findings. I'm not a clinician. I'm just a full-time researcher and teacher. But we have like a second part of presentation focusing on clinical side of services. So my presentation is mostly about research evidence. And here are things that I'm going to share with you today. So a variety of different DV types. I'd like to briefly introduce you to them, and impacts of DV, domestic violence, on children and family, and what children and family are affected by DV do to cope with the aftermath of victimization or exposure to the violence. These are 3 things probably I'm going to spend for 10 minutes, very briefly, and followed by culturally competent approaches, especially for Asian American and Asian immigrants. I'm sorry. And in the process, I may have a chance to introduce some cultural characteristics of values or attitudes toward coping, like stigma and shame. And after introducing the culturally competent approaches, I'm going to move on to trauma-informed approaches. Especially DV is very violent, traumatic event. So like good understanding and application of trauma is very important. And because of the nature of domestic violence, by nature is multi-generational, like parents abusing, neglecting children, or children are exposed to parental violence, or siblings fighting each other or abusing each other, and grandparents and extended families and relatives step in to help something like that. So it's kind of multi-generational transmission of violence or trauma is kind of very common. So any good trauma-informed approaches may be able to address that element too. And across my presentation, again, I'm going to introduce a few research evidence. But like as a starter, there's not many studies on Asian American and Asian immigrants, especially relate to domestic violence and especially relate to trauma-informed care or services. So just be aware, many of my sharing of research evidence may not be specifically on Asian Americans, but instead like racial ethnic minority behaviors, health, that might be included too. All right, then let me give you a brief introduction of DV, domestic violence. So this is not exhaustive list of domestic violence, but first, intimate partner violence, violence happening between intimate partners like couples, spouses, ex and current, or boy or girlfriend, something like that. It includes like a physical, emotional, psychological, sexual, technological, financial, economic, whatever forms of violence can take place. And next form of domestic violence might be sibling violence. So like all the siblings like abusing or manipulating younger siblings or the other way around. And elder abuse by either family members or caregivers. And child abuse and neglect committed by either their parents or caregivers or neighbors or strangers or community members. And children are not being directly victimized by violence like abuse and neglect, but they can be exposed to whatever different forms of violence like parental violence or sibling violence, something like that. And domestic violence, shortly DV, has enormous impacts on children and family. First of all, it leaves very serious physical and mental health problems. So including like headaches or like the, insomnia, like eating disorder, like the pain or something like that, or depression, anxiety, or suicidal ideation, something like that. Very common among children, family affected by domestic violence. And if they are in the academic setting like students, then their academic progress and achievement tend to be very negatively affected because they cannot focus, concentrate on their academic side of their life because all other side of their life is either very disruptive and destroyed even by violence. And social problems. So because like DV happens in family, most of the times we assume one of the safest place in the world. So typically if we have a hard time or challenges, we just turn to our family members for comfort and compassionate hugging and even food. But because of the presence of violence, that kind of belief is just shattered. So it creates larger social problems. They are afraid of connecting with others because they don't know, like they just lost very trust of human nature. And if they are victimized or exposed to violence, they are more likely to be either perpetrator or victims of violence in the future. But it's kind of like the tendency, but we cannot generalize. For instance, every violence victims at childhood will be either perpetrated victims. That's kind of like the nonsensical. But on average, at least they are, if they experience domestic violence early on, they are higher risk of either being perpetrator or victims in the future. Because of such serious impacts of domestic violence, children, family, after affected by violence, they did their best to cope with very negative aftermath of victimization or exposure. So I listed some of those coping mechanisms or tactics that commonly utilized by children, family. So let me start from left side. I believe like that this kind of knowledge may be very common among us, including audiences. So let me be very brief. So many children, family, once they are affected by violence, they tend to ignore their feelings. They feel angry, sad, frustrated, and something similar. But like because of the confusion that happened in in family settings, so all of the happening surroundings just became confusing to them. So even they may not understanding of their own feelings. And because of like victimization or exposure, that experience, they may feel survivor's guilt or even shame, like thinking like they must have done something wrong, so that they are like family members like felt it's necessary to punish them by violence, especially for children's perspective. So that's pretty common coping. And even some of them use substance like alcohol or drugs to relieve some pain associated with victimization of domestic violence. And developing some codependent relationship. So because like they experience like betrayal of like intimate relationship or family relationship, they want to like compensate that loss of family connection by spending too much time and effort caring for others. So that's not healthy coping mechanisms. That's the left side is usually labeled as negative coping behaviors. Whereas this right side may depict it as a positive coping, like they can set clear boundaries and they can gradually heal from wounds and they can start rebuilding relationship, gaining a little more trust onto human beings, and they can forgive themselves, so escaping from guilt and shame. But I believe like any of these, although I labeled them negative, they are not innately negative. For all of us, if we experience lots of adversities, then probably all of these things kind of very common, even positive coping mechanisms. But it may be problematic if we stay too long onto this side. And obviously, all those coping doesn't happen just individual level. So if they have very good support system, of course, their coping with domestic violence will be improved a lot, that they can get back to the prior status before victimization more quickly with the support system. So thinking about support system, then we can frame that as like a help seeking. So they can report their victimization experience to police to get some support, or if they got injured or some health problems, they will visit healthcare and psychologist, counselor, mental health therapist, and they may stay at shelter if they have to leave their family because perpetrator just stay there, or if they getting through some divorce, separation, or custody issues, the legal services may be some of those sources that they use. So because all those services are provided by professionals by train, we may call all of them as a formal sources for support. Whereas this right side lists some kind of like informal sources for support, including family members, friends, co-workers, and religious leaders. Because sometimes like the seeking help from professionals can be expensive and may not be affordable to many children and families. So they have to turn to informal help sources, or because it's just convenient for them to talk with them. And even if it would be better if they share some cultural characteristic values with them. Sometimes formal help sources do not share same cultural values, beliefs as clients have. I mentioned earlier that we expect positive outcomes from help seeking, but not every help seeking turns out to be positive. So I listed some research results showing some negative outcomes out of help seeking. So like some children family utilizing DB hotlines programs reported a little bit increase in mental symptoms. So for instance, children, if they have to stay in shelter, they may be isolated from their peers. So their kind of a little bit anxiety, something like that will be increasing, something like that. For male survivors or boys, formal sources seem to be less helpful than informal sources, as well as compared to girls or female family members. So we suspect that maybe like most of services for DD designed for female adults or girls, so that male clients do not feel like belong to the service, and it may affect service outcome negatively. Or some of those boys may have a mentality like boys don't cry. So they may hide their emotion or whatever through sufferings. So it hampers treatment outcomes negatively. Similarly, we observed LGBTQ children and family found formal sources less helpful compared to informal sources for help, as well as compared to heterosexual non-LGBTQ children family. For this, we suspect that probably like similar to males and boys, and many services may be designed for heterosexual or with a limited understanding of gender non-binary clients. And some of them may feel like service providers having a little bit of homophobia or culturally insensitive attitude toward LGBTQ. For instance, like when they reveal their gender identity, when they found like service providers suddenly look out for facial mask or like the latex gloves, like thinking like the LGBTQ children family may just innately bring in some kind of disease like HIV or sexually transmitted disease. Is totally out of sense, but if service provider, either because of ignorance or lack of training or understanding, if they show that kind of behavior, then probably they wouldn't visit that healthcare site ever again. And immigrant children and families seem to find informal support sources more helpful than formal sources. It may be related to culturally competent services by service providers. So including like language. So at this moment, I like to switch into culturally competent services. So in general, when we say culturally competent services, we include the three essential components in it. First is we have service providers have a very good understanding of variety of different cultural characteristics, values, beliefs, and attitudes. And secondly, service providers can apply those understandings of cultural competency onto their practice field. And lastly, they keep trying their understanding and applying them, and they will learn from trial and errors of their practice, because their application of cultural understanding may go wrong, or is a little improper, or less sensitive way, so that it may be, it may be offensive to some cultural clients. So but they will learn from them, and every time they apply, they will reflect on the feedback and outcomes of treatment, and they will modify their services continuous basis. So that's kind of what I meant when I say culturally competent services. So because today we are talking about Asian immigrants, let me give you a quick statistics about Asian Americans. So they are fastest growing racial groups in the US, accounting for about 6%, and in number 20 million. And over 60%, about slightly less than 2/3 of them foreign born, and 1/3 US born. And they coming from at least 43 different ethnic groups, and they speak over 100 different languages and dialects, very diverse in some. So that diversity may reflect on this geographic diversity. So when we say Asian, then we may mean Mediterranean, Arabs, and Stans countries, and South Asia, Southeast Asia, East Asia, like mid and northern part of Russia, all together. So very diverse. So it's almost impossible for us to generalize whatever things as Asian. In addition to that, we see I mentioned generational differences, and I mentioned ethnic racial differences. And we can add gender differences too, and social class differences. So altogether, whatever combination of these identities may affect their cultural beliefs, and they may affect treatment outcomes too. So let me give you like the two graphs that shows some characteristics of Asian Americans, Asian immigrants. So this first graph shows percentage with any mental illness reported in past year. So I believe this report was from 2020. And using like 7 racial ethnic categories. So multiracial, non-Hispanic American Indian, Alaskan natives, non-Hispanic white, non-Hispanic black, Hispanic, non-Hispanic native Hawaiian, Oceanic Pacific Islanders, and non-Hispanic Asian. So multiracial at the top in terms of prevalence. So it is a vertical black line represents average. And we see Asians at the very bottom, which means reported mental health prevalence is lowest among Asians. So which is good, right? So we are strong, but that may not be true. So let me give you another graph. So this is kind of percent of clients receiving mental health services among those who reported any mental illness in past year. So among these, how many actually utilize mental health? That's what this graph says. Again, white at the very top, followed by multiracial. And Asian is almost the bottom because other two categories very small and statistically insignificant to show. So if we ignore these two categories, Asian is lowest, which means even though they may suffer from mental health issues, they are less likely to seek services. So we suspect there may be some disparities because of that. So in general, not only for Asians, but in general, ethnic racial minority has some disparities like less success and availability of services, and they are less likely to receive services if they are available. And if they use them, probably they reported poorer quality of treatment compared to non-minority population. Above all, like the minorities are heavily underrepresented in research. So most of like research based on white and male population. So very small number of Asians have been included in research. So lack of that research affects all areas of like less number of service providers, less number of like the service organizations that are equipped well with cultural understanding. And I believe like the previous very first webinar mentioned and discussed the barriers of service utilization. So I'm gonna go very quickly about these. So these are common barriers that are typically observed for Asian Americans, Asian immigrants. Cultural dissonance. So they found service providers or like facilities are culturally insensitive. And they found communication difficult because of language or some cultural differences. And again, stigma and shame. And lack of research, as I mentioned earlier, and lack of culturally competent implementation. So it takes a long time and a lot of resource for any service providers implement cultural competency service provisions. So they have to first establish a culture, they have to good plan, they have to train all staffs, and they have to secure good resources, and they have to keep monitoring if their culturally competent services are implemented as expected and outcomes are as expected. So with that understanding, let me go to the trauma-informed approaches. So it's especially important because we are talking about domestic violence, leaving serious trauma onto children and family. So when I say trauma-informed approaches, I believe like most of you attendees and folks today understand very well about this. But in some, like when I say trauma-informed approaches, I mean like the very similar things when I used when I describe culturally competent services. First, service providers have very good understanding of the nature of trauma and its impact on our clients. That's first component. Secondly, good service providers, trauma-informed service providers will be able to apply their understanding about trauma onto their practice. And lastly, they will keep reflecting on their practice and keep improving their services. That's what I meant when I mentioned trauma-informed approaches. So here are some essential principles that we commonly found from trauma-informed service providers. Most of them reflect on understanding of trauma, as I just mentioned. And many of the service providers address both physical and psychological safety concerns. As I mentioned earlier, because they are affected by DV that happens family settings. So safety is kind of utmost important area to be improved for them. And they will use the culturally informed and strengths-based approach. So strengths-based approach, like it means quite opposite of like deficiency-based or pathological understanding of our client situation. Although like they are affected and negatively affected by violence, we don't depict them as like passive recipient of trauma or treatment. We believe they have their own strength and they made the best choices, best decision in the process of healing after domestic violence. So we trust on their strength and we try to use their strength and tap on those strengths to help them get back to the like optimal health conditions as fast as possible. And any good trauma-informed service providers will help to illuminate the nature and effects of abuse on survivors' everyday experiences. And ultimately, their goal would be to provide opportunities for clients to regain control over their lives because they lost so many things about their control. They lost control of their body if they are victim or they are exposed to violence. So getting control from beginning very small things and moving toward bigger and bigger and full control, it may take time, but trauma-informed service providers will help our clients to reach that goal safely and as quickly as possible if that's available. And I mentioned some essential components. Then this is kind of a common service components that we will find from most of trauma-informed service providers. So identification. So good service providers have a very good mechanisms of identification of those who are affected by trauma. So it includes like a very good screening tools and intake process and very good measurement assessment of trauma of our clients. And that assessment should be done very culturally competent ways. And they will make sure, again, safety is utmost important and like encouraging them to express their feelings and ensuring that whatever happened was not their fault. So it's not their fault and they don't have to feel guilty and shameful about their own sufferings. And they will try link families with community-based services because every client has a different, from different background, different experience. So they have very unique needs. So like for children, probably educational and social needs may be more important than others. But for adults or householders, probably employment or small business training or financial literacy, that kind of services may be more important than the other. So linkage is very important in trauma-informed approaches. And also important is like a support for the staff in shelters and service providers, because they try hard to understand the trauma of their clients. Sometimes that understanding, that trauma may transfer to staff themselves. So they may feel the similar anxiety or like depression or something like that. So like establishing some kind of mechanisms and like the helping service staffs avoiding some secondary victimization experiences. Too much exposure to trauma may make them vulnerable. So that kind of service provision for themselves may be equally important. And overall, establishing good service coordination is a good thing, and that we can find from good service providers. And let me share some outcomes of trauma-informed service provisions. So like many of clients reported overall their self-efficacy, like they found their own strength and they believe they can find the resources and they can overcome or deal with some future adversities by themselves. And they feel like higher safety-related empowerment. Again, like they can locate the resources and they can utilize good support system and avoid like some bad influences from community and improve the mental health symptoms. And if parents, children attended services together, many of them reported back like program provided a good moment for them to reflect in that difficult times. And especially for children, if trauma-informed services implemented in a little bit playful way, in which children may feel, yes, they can see or touch or express something. So they don't have to hide behind. So that might be the beginning of their healing and recovery or change. So that kind of like very children-sensitive provision will be very important. But some parents find it difficult to attend the program, either because of transportation issues, if they stay in shelter, or if they have to travel a long distance to reach the service providers because their community do not have good service providers. For whatever reason, many of parents found it very difficult to attend. So it may imply that there may be strong needs to develop outreach program so that we can reach out to the folks who need our service the most. And I believe this is the end. I just skipped 1-2 slides. I'm very conscious of time. And the last slide of my presentation have references. So I believe if you ask for some presentation materials, you can utilize some of these references for your use. And I'm just to take a pause here. Thank you so much. Just enduring my like jumbling, mumbling, whatever sayings. But I'm open to questions and some suggestions for discussion.
Thank you, Dr. Cho. Yeah, and I see all this interaction and saying like heart and clap. Now we have like around 6 minutes of Q&A until 12:45. So if you have any questions, please feel free to put your questions in the Q&A chat box, and then I will help and ask Dr. Cho. So we have the first question now asking about how do you encourage those cultures who do not acknowledge domestic violence as abuse to begin to set those like boundaries and move towards healing. That's the next step. And they just like do not feel that it's disrespectful, dishonoring, or like just bringing shame to the family. So in this specific situation, how do you convince the family that actions may have caused hurt?
Yeah, of course, like probably we may start from like giving absolute validation to their sharing, because they suffered from violence from like interested like the family members, or they exposed to the violence. So they are losing trust for whatever. So they just including their own like self-esteem and their sense of self-value. So they may be very afraid of sharing at all. So probably like the not judging them at all. And I mentioned like when I discuss like coping mechanisms or coping skills. So ignoring feelings or like using some substance. Overall, they may be negative in the long run if we stay for a while using them. But in the short term, they can be very helpful. They can help like the overcome some kind of like the sudden surge of anxiety or depression. So like as a family member, if we witness certain behavior that in otherwise we may label them problematic or something to be corrected, but we have to be understanding of this situation. So probably we have to be very patient until they just come out and just they trying out multiple tactics, and some of them may be seemingly negative to others, but they are doing the best theirs. And that's probably first thing. And secondly, probably like especially sharing about mental health concerns, maybe strong stigma in Asian communities for where I'm from. So we don't admit that we are sick. So it's kind of because of my willpower is weak. So I can just meditate and seek for some higher level of something, then I don't need any outside help. And seeking help from outside actually detrimental to strengthening my own. So probably I may be more vulnerable in the future. So whatever like that nonsensical way, I frame that way and I observe many sharings of such belief. So understanding that and just addressing properly may be another way to discuss with them.
Thank you, Dr. Cho. I agree with you. And I think like sometimes the clients will feel like, oh, I seek help because I am weak. But actually, we need to redirect them. Seeking help actually is because you are courageous. You have courage to acknowledge you need help and going a step forward that I am deserve and accepting help. So there is another question. I know that Dr. Chu, you have your reference in your slide because there is a specific participant wants to see your reference for your study. Do you mind like going to the last slide of your presentation so that everyone can see it?
Yeah.
Yes. Okay. So if anyone have questions, then please feel free to put in the Q&A chat. There's another question for you, Dr. Cho. What is the most frustrating aspect of your work? And how do you manage these frustrations so that you can keep going?
Maybe like a current political situation, but I'm kidding, but I'm not kidding. But other than that, like because domestic violence doesn't happen at only individual level. So it happens because either our society allows it or perpetrators do not feel if they commit this kind of like the criminal behavior, they may be safe. They may be saved from criminal persecution. So like social policy is too lenient for specific subpopulation, but too harsh onto another subpopulation like male or boys or LGBTQ immigrant population, they are too harsh. But for others, too lenient. So they feel like okay, do whatever they think. So, but like correcting them, educating perpetrators or changing social beliefs about domestic violence takes a long time. So we tend to a little focus on like something that we can see short-term outcomes rather quickly. But in the process of doing it, sometimes we are not consciously, but inadvertently forgetting about big picture. So like we help our clients perfect. So they regain their control. But once they leave our session, they are facing discrimination and sometimes stigma all back to them. Then probably their short-term gain from our work may not last long. So I'm a researcher full time, but whenever I write paper about those these for social change and observing a little bit less work done on that side, I cannot say the most frustrating part, but that's frustrating.
Thank you. And because of the time, there are still 2 questions asked by the participant, but maybe we do not have enough time to address those 2 questions. Dr. Cho, do you mind if you can just go to the Q&A function? And there is like a type answer function. If you can spend time to just type in your answer during the next presentation, if that's okay.
That's a good way of spending my time. I like to observe the next presentation, but I will save some time for that.
Thank you, thank you, thank you. And
let me start sharing my screen.
Yes, and I will introduce.
Oh, you already did? Okay.
Okay, yeah, I will introduce our second speaker for the presentation. So our second speaker is Dr. Shilpa Kapoor, a psychologist, trauma specialist, and relationship expert. Dr. Kapoor is licensed in California, New York, and Virginia State, who is also the CEO of the group practice Mind Body Care in the Bay Area with 2 locations. She does direct clinical services as well as supervise, run trainings, and community presentations for clients and professionals. Her areas of interest are intergenerational trauma, resilience, and post-traumatic growth. The second presentation actually will be co-presented with Sunita Roychoudhury, a licensed marriage and family therapist, licensed professional clinical counselor, and a certified international neuro-linguistic programming (NLP) coach. As an artist and a therapist, she has a deep appreciation for reflective process. She collaborates with clients in an integrative, holistic approach to cultivate and honor their inner wisdom using mindfulness, art, and somatic practices. Please allow me to welcome 2 speakers. Thank you.
Thank you. Cruz, you can hear me, right?
Yes, I can hear you.
Okay, great.
Loud and clear.
Okay, perfect. Thank you so much. I appreciate this opportunity, Cruz and Team Lotus, for this great opportunity and inviting us us clinicians to talk about this much needed topic and hopefully to raise awareness. As Cruz mentioned, I'm a licensed clinical psychologist here in California, and I'm also a California State domestic violence counselor. So we're going to talk about clinical implications and interventions when we are working with Asian American community, especially when it comes to domestic violence and intimate partner violence, DV and IPV. So I'm going to focus more on parenting and children. I'm going to talk a little more about how this impacts when a victim is, subject to violence at home, how that impacts that person as a parent, and how that impacts the children involved in that situation. So when we are talking about children, in child caregiver relationship is a very mutually influential one. What I mean by that is that what happens to one impacts the other. Especially in DV situations, this is even more so. Children in DV situations and IPV situations are direct or indirect witnesses, and sometimes are the silent victims of IPV DV. When we talk about children as direct witnesses, when they are themselves subjected to abuse by a caregiver. And when we talk about children as indirect witnesses of DV, IPV, this is when they themselves are not directly subjected to any kind of abuse in the household, but when one of their parents is subjected to abuse. So when that parent is subjected to abuse, this impacts the mental health well-being of that parent, which again, in turn, impacts how they parent their children. So their parenting abilities are impacted. So that's what we call children as indirect witnesses and victims of IPV and DV. This indirect impact on parent difficulties shows up in these parents in the form of this victim being sad, depressed, anxious, angry, fearful, disengaged, not attuned in to the child's needs. They have low relatedness quality, and they often use certain not so adaptive, or what we call maladaptive coping mechanisms, such as drug, alcohol, not sleeping well, not eating properly. And this impacts their mental health as parents, and then this impacts their parenting abilities. I'm trying to, okay. So when we talk about impact on parenting, just continuing with that, a couple of more slides. For these parents, children can become triggers. They start seeing children as, children can remind them of abusers, especially when children start to say, not listen, they're misbehaving, children being children, right? They do all these things, right? And then they also sometimes start hitting this parent, the victim parent, especially they're imitating the behavior of this parent. So they start hitting the parent. And in this situation, the victim parent may also start feeling, they start having triggers, children become triggers for them, such as they start feeling like, oh, my child is betraying me, or my child is rejecting me, or my child is now acting like the abuser, right? So they start feeling abandoned by the child. These parents also often feel failures as parents. They have guilt, shame about not being able to protect their children, especially when children were also, abused by the other parent. They take it personally that it is their fault that not only they didn't protect themselves, but they also could not protect their children. They could not provide a safe environment for the children. These parents also often engage in overcompensation and overpermissive behaviors towards their children. They try to, this is again as a way to try to see if buying additional gifts, buying love of their children through gifts will help undo the impact of trauma that was subjected on the children, right? They try to meet all the demands of their children. Needs versus wants, we all know the difference. So they focus more on wants, right? These are sometimes what we call desperate approaches or quick fixes by these parents. We all know it takes a village to raise a child. And when these parents who are victims themselves, who have traumatized themselves, they're already running on empty tank or have very limited resources. They also don't have much time, and raising children requires a lot of patience and time. And so these parents tend to use certain overcompensation or overpermissive behaviors when they're parenting the children. I've also noticed in clinical settings, these parents also sometimes are overprotective of their children. They do not, because the family has gone through, say, separation or this kind of loss, they're grieving, they also try to overprotect their children by shielding them from stressful situations. In these situations, children tend not to develop enough adaptive coping mechanisms when they grow up, because life without stresses is not possible. Life without adversities is not possible, right? Things are going to happen, challenges are going to happen. But these parents, because of them trying to overprotect their children, overshield their children, these children also tend not to develop enough adaptive coping mechanisms when they grow up. Many times we've also seen these parents engage in harsher punishment towards their children, because parents themselves don't have patience. Grief and loss is pretty common in these families. Loss of the parental relationship, grief and loss of resources. Raising children as single parent versus raising children as in one household, that additional grief and loss also impacts the parenting abilities. Loss of resources also impact parenting abilities. We've also noticed, especially in the collectivistic culture, because of shame and guilt and stigma associated with loss of relationships, parents also isolate themselves. When parents separate, there's a loss of common social circles that is lost. Parents also tend to isolate themselves. So these are some of the challenges I've experienced when I'm working with these parents. They talk about that these are the challenges they have noticed. So very briefly, talking about how this shows up in the clinical setting. I'm not going to go in detail because we are all aware of this. So these parents show up when they are traumatized. They show up from clinical symptoms that I've seen is hypervigilance, overprotectiveness, emotional dysregulation, grief, loss, trauma, grief, loss, shame, guilt. We already talked about inconsistent parenting, triggers and flashbacks, difficulty setting boundaries, Overcompensation or people pleasing is very common, and avoidance and numbing, and many more symptoms. I'm sure if based on your clinical experiences, you would also see that there could be a combination of these symptoms or many more symptoms that we have observed in our clinical setting. So when we talk about when these parents come in the comfort therapy, I always start with psychoeducation, because jumping to doing any clinical intervention I've seen is not that helpful, especially when these parents are or children are in the unsafe environment. So I start with psychoeducation. I come across this statement a lot from these parents: oh, we will stay in this environment even though there is abuse, but at least the child or the children are getting both the parents in the same household. I'm not saying you separate, but I also tell them, hey, you want to see what are the long-term emotional, physical, mental health, well-being outcomes are if you are in two separate but conflict-free environments versus one household where everyone is together, but there is ongoing conflict. So I start with that psychoeducation. I talk a lot about what are the protective factors in children. Protective factors are stress-free environment. Protective factors are parents who are engaged, parents who are attuned. It can be a single parent. Also talking about safety first. It's hard to do any kind of clinical intervention with these parents if they have to go back to unsafe environments. So if they have to go back to unsafe environment, then we talk about how do they know, like, what are their rights? Empowerment, like Dr. Cho was mentioning about, what are some community resources available? What are their legal rights in situations like these, right? Also connecting them with some community support, such as domestic violence agencies, where they can get some culturally and linguistically appropriate care as well. That is another way we talk to them about some protective factors for the parent as well as for the children. We also talk about risk factors in children. And these risk factors in the long run are going to impact children's mental health, physical health, academics, social relationships, their own intimate relationships when they grow up. I also talk about ACE, which is adverse childhood experiences, and the impact it has on children's emotional, physical, educational, social, and recreational well-being, short-term and long-term. Then we talk about trauma-informed parenting. This is especially in this situation where a traumatized parent is trying to take care of a traumatized child. So this requires a lot of self-awareness and healing, first by the parent. If parents don't focus on their healing, it is going to be pretty hard for them to support their child, because unresolved trauma can impact emotional regulation, empathy, and response to stress. Caregivers are encouraged to prioritize their own mental health through therapy or support to break cycles of reactivity and create a safe, nurturing environment. Building trust, practicing patience, using trauma-informed strategies are essential to help children and caregivers heal. So we encourage parents to focus on their self-care, focus on self-compassion, because if they are running on empty tank, if they are not wearing their oxygen mask first, it is going to be hard for them to support their children. We also teach a lot around what are some of the triggers they are experiencing, like common triggers and how they may affect a parent's behavior as well as child's behavior and emotions. It's important for parents to first recognize their own triggers and learn to manage them so they can help children manage their triggers. Something called co-regulation. Continuing with trauma-informed parenting, we also talk to parents about, we try to resource them. I break it down into insourcing and outsourcing. Insourcing is taking care of yourself, self-care and self-compassion, and outsourcing is connecting the child with safe community resources, say coaches at school or teachers at school, therapy, other positive role models where children are getting a different relational experience. Talking to parents about self-compassion, we know self-care, exercise, sleep, food, that is something we all hopefully engage in, but also talking about self-compassion. It's learning to forgive themselves, especially because victims tend to blame themselves a lot, uh, not being able to protect their children. Also, teaching parents to be kind to themselves. They learn to be harsh on themselves. They learn to blame themselves as a way to cope with what happened. So, teaching them to try to be try to be kind to themselves, and also try to teach self-compassion to children also. Also, fostering social connections and sense of community. We already talked about the importance of that, especially when these parents are not able to seek therapeutic support. They are not able to, they don't have resources to receive therapy. Then at least connecting them with some domestic violence agencies where it is free care, anonymous care. They don't have to share their name. Nobody's going to come home and say, oh, this is going on in the house. So we try to provide education around that also. Some other interventions I use are also identifying and reducing barriers to seeking help. I'm not going to go into detail. We have already talked about it. Education around intergenerational trauma and the benefits of breaking the cycle. Many times we've seen in certain collectivistic culture, self-care is considered selfish. So giving education about, hey, self-care is not selfish. It's if you take care of yourself, you are going to show up from a different place when you're trying to take care of your children. Talking about boundaries, I tend to use the word needs rather than boundaries in collectivistic culture because boundaries can come across as being selfish. So what are your needs? A need for safety is a very basic need. Need for you to take care of yourself is important. So helping them focus on their needs because many times they're not used to that, right? Also, they have internalized messages such as, it doesn't matter, it's an abusive relationship. I am supposed to be in this relationship. This is the message I got growing up, received growing up. Talking about rigid gender roles, acceptance of abuse as a private matter, familial loyalty, obedience, shame, and guilt. I also focus a lot on epigenetics and neuroplasticity as I'm giving education to the parents, to the families, focusing on strengths, survival strengths, and resilience within a cultural framework. Addressing immigration concerns. Many people don't talk about what is going on because of their visa status. So it's important, I feel, for me to know as a clinician, what are some available resources available for these people, or for the victims, especially when there is immigration issue. Also, coming from a preventative place, early intervention and prevention is very important. Talking to men and boys, involving men and boys in preventative efforts, I feel also is a great way to shift cultural norms around masculinity and violence and patriarchy. I'm going to stop here.
So good afternoon, I'm Sunita and I'm a clinical director with Mind Body Care, and I'll focus a little more on domestic violence, codependency, and how that shows up in our clinical work. So I'll just begin with the first slide where I've just identified, for me at least, the three main markers in what I see people from collective cultures show up as. So the first would be the emphasis is more on collectivism over individualism. Thinking and behaviors are passed down through generations via storytelling, socializing, and that message is reinforced consistently by the family and through the community, intentionally or unintentionally. So if you'll see the two examples that I've shared here, both showcase that emphasis is on collective harmony and not stepping outside of the community when it comes to solving problems or addressing inherent challenges because of domestic violence or IPV. And lastly, in collective cultures, the individual's identity is tied with their sense of group identity. They are not separate. So if we move on to the next slide, as the two speakers before me have shared how domestic violence shows up in collective cultures, I'm just reiterating that in some collective cultures, domestic violence is usually part of the social norms, and it is either through social or traditional rituals or formats. It's just conditioning that is reinforced to the people from that culture. So one example I will use is oftentimes parents discipline their children by hitting them, and they see this is a correct way of doing that. And there isn't another alternative. Another example could be somebody who is experiencing domestic violence or is unable, like there isn't room to actually share their pain, because that is seen in some cultures as being disrespectful, that you're even talking about your pain. And in some collective cultures, like rituals, traditions are used as a way to to justify abusive behavior. So say, for example, a husband can hit his wife, saying and justifying that that's okay to do that because traditionally he is the one who enforces authority in the culture, in the family, and how his family shows up in the community is also a representation of him. So moving on to the next slide, I'll actually focus more on how codependency and collective culture characteristics actually show up very similarly. So if you look at the box where I've identified just 5, and there are more, as we know, there are more characteristics for codependent behaviors. If we kind of look at that box, and then when we shift our attention to the collective culture box, you'll see there's a lot of similarity. For example, if I use decision making is based on, if I'm working with a client and I check box that decisions are based on what is best for the group, I may tick off like they are self-sacrificing and have a tendency to focus on others. If I see that a client is focusing more on common goals than their individual needs or interests, then maybe I'll say that based on my training, they have difficulty recognizing and expressing their emotions and needs. Again, if I look at the rights of the families comes ahead of the individual, then maybe I may assess them as being very enmeshed and not very independent. So based on, like Dr. Joe and Dr. Shilpa Kapoor also kind of talked about strategies, and I'll just lightly touch on them since we've been kind of talking about that. So in the next slide, pretty much like all 3 of us are saying that psychoeducation is very important. Using the cultural lens is very important in how you reframe domestic violence, emotional abuse, verbal abuse, codependency, enmeshment. And really having a conversation, how that lands for the client when you're even providing that psychoeducation. I think as Dr. Cho also mentioned, validating the client's fears or feelings or just their experience because it's been minimized and dismissed is very vital to keep encouraging that so that they don't feel, again, they don't have that similar experience of being made small. Normalizing, on the third strategy, just normalizing like the struggle and the shame and the guilt that an individual feels when they have to take some hard steps, like maybe separating from their family due to safety. This can in some ways show up as fragmentation in their identity, because if we are saying that their identity of the self, the individual, is intertwined with the group identity, then that starts creating a fragmentation in some ways because guilt shows up. The fourth way, I think, when I'm working with clients, I often ask what groups and social communities do they find helpful and not helpful? Because when you come from a collective culture, it's really hard to form associations outside of your culture. So I think identifying and evaluating that with your clients is very important. So I'll move on to the next slide. I just want to highlight that codependency is on a spectrum and it's on a continuum. Codependency in our training usually is associated with addiction and substance abuse, and it isn't always that. So when we are working with clients specifically from collective cultures, just to be mindful not to use that as a way for assessment. And diagnosis, like codependency, isn't a diagnosable mental health disorder anyway. The other thing is when you're working with clients, it's important that the meaning making that they make of their cultural values and perspective is important, like really understanding that and exploring that, because I think that would help in terms of case conceptualization or even treatment plans moving forward. And using that, I have found it often helpful using the framework, even working with clients, to reframe how maybe they are repeating some of the patterns because it is generational learning or traditional views that they have been taught. So they are fighting like the sea of years of, family culture, heritage, a lot of this background. So it's very difficult to go about making these changes. So moving on to the next slide, I'll kind of highlight a little bit, how clients actually present the impact of DV in therapy sessions. For example, a client may say, my family will disown me for leaving my partner because they think I'm betraying them. So the next two slides actually supports what I'm saying, and I'll elaborate on that. Because when I hear that, I kind of think, okay, the motivation where this client is coming from is guilt and shame, but that is tied to maybe family honor, maybe fear of being rejected, maybe fear of isolation, or just lack of understanding of what abuse is in general. We've often heard, some clients say, my family is saying I'm making a big deal about this, and this happens all the time, and I need to accept it and move on. So this is also a way of actually dismissing and minimizing because of cultural conditioning, as well as family pressure. So I'm going to focus a little bit, like especially when I've worked with children, sometimes a child will say, I want to kill myself because I'm tired of seeing my parents fight. I think in that moment, it's really important to work with a child and understand, is this truly suicidal ideation, or this is just a form of expression that they are using because they don't have that emotional vocabulary, because that's not been modeled to them. And it's the same thing in terms of, sometimes children say, it's okay that I hit others, like in my class, because I see my parents hit each other. So it's that same model in cultures where violence is a norm, and children just see that in terms of interactions with their family members or in the community, they just enact that. So these are some ways that I have found, just some examples that I have found that it shows up in therapy. So moving on to the next slide, which will build from what I just shared, I often tend to hear, when clients are sharing this, how guilt and shame falls in these categories. And there can be more categories, but largely it's family honor, social stigma, gender roles, patriarchy, just fear of complete loss of any kind of support from the family. So those, like, just touching on how these become barriers as we move on to the next slide. So in terms of social stigma may show up as fear of retaliation. It may show up as, the decision making is more on a collective approach. So the two things that I'll highlight in this slide that I have seen happens a lot of the times, where maybe this is happening, but a lot of the time the motivation is to reconciliate instead of justice, because for some clients, it's more distressing to be separated from the community or from their family. And that creates more distress. And that also shows up in terms of their identity feeling very fragmented. So the motivation is, how do I still stay in group harmony? Because I'm from a collective culture. That's how I identify, not only as an individual, but also in terms of my group. The other thing that I think all of us have touched on is, that sense of generational trauma that we see, and how that is difficult even as clinicians to change that belief system. and why that cycle is difficult to break and why that cycle gets perpetuated. So that's the two things that I'll say in terms of our work. It's really slow and it's like really supporting the client and going at their pace and not at ours. So that's the thing that I will say in terms of resourcing. So moving on to the next slide, where I feel this is the toughest part, working with people from collective cultures, especially in these difficult, really complicated situations, balancing, when do we discern that a client, you actually have to tell a client, you have to separate yourself from this situation because this is no longer safe, versus you working with the client and actually discerning using psychoeducation or a treatment plan with the family, the community at large might be a more effective strategy. So I think this is the tricky part I often find, and I use consultation a lot. Like, how do we balance the culture versus the individual in these circumstances? So some questions that I ask is the individual living with the family? Then again, just as Dr. Kapoor said, that even I kind of frame boundaries as needs. So what kind of interactions do they feel comfortable following through on and setting while they are living, maybe with the perpetrator, maybe with other community members? So how do we do that? The other thing, when they're living away from their family and they may be in the same city, oftentimes I have found in sessions, I am just working on managing that sense of guilt that I am away from this situation and my family has these expectations and my community is pressurizing me to show up in this way, or they are telling me, take back some of these things that you're saying. So I think just understanding what that situation is and what they are comfortable following through on. The other thing I found helpful is actually asking the client, what do they feel comfortable in terms of disclosure of attending therapy? So do they want to include their family? Do they want to include community members? Do they not want to do that? Also, in terms of if a client has chosen to stay separately and they've arrived there on their own without our help, then it's more about, okay, what is the strategy that we want to use in terms of feeling safe? So what do you want to disclose in terms of separating from your family for the time being? So I think this question of safety, it's very important to understand when they feel safe or comfortable involving authorities. And I think I have often found this helpful, where this is the point where I educate, hey, when you tell me some of these things, I'm a mandated reporter and I have to do all these things. So let's kind of create a plan where I actually don't have to without your permission, I have to take this step. So this is something we definitely plan on. And again, just going back to how so that there's ongoing care, we kind of focus on what communities our clients feel comfortable or uncomfortable attending, so that they continue to have this additional support. So the last slide, I will not focus so much, since we've talked a lot about what practitioners need. And I think I'll reiterate what Dr. Kapoor said. I think it is just the first step is actually, as providers, just helping regulate their nervous system before we start any intervention. Because if they are so traumatized, there's no way they'll be able to really take in any treatment that we work towards implementing. And the other big thing is really identifying our burnout and how we experience that, because this is a lot of trauma that we work with. And the other thing is, like, during consultation, really checking on what your biases and judgments are when you're working with clients who are survivors and what their perspective is. So with that, because of time, I'll end the presentation here and I'm open to questions.
Thank you. Thank you both for your presentations. Now we will have Q&A until 1:25. That will be 4:25 in the East Coast. So currently we have 4 questions. Hopefully we can cover all this. So the first question is, how are abusers help when they initiate seeking help? So like if a perpetrator coming and I say, I need help, they are abusers. How are they going to be helped?
Shilpa, do you want to answer that?
I was trying to go to the screen. Sorry about that. Just let me start the presentation. Otherwise, it's kind of little. There we are. Okay. So yeah, how the abuser. So, as far as I know, what research I have read, some of if they are taken through the legal system, something I've observed, what my understanding has been, they are put into what we call 52-week or 54-week anger management program. And research, I don't remember the research, but I can dig into that. Research has shown that tends to not change anything. Because when we are talking about abuser, we are not talking just about the behavior. How did they reach this place? The intergenerational factor, the patriarchy, the messages they have received, the normalization, the socialization, the the upbringing, if they observe this happening in their family of origin. So a lot of factors are there. It's just not the behavior. Behavior is just one factor. Personality issues. We also know many times abusers tend to have some personality traits, if not disorders, which are hard to change, right? So it's hard. So when they come, of course, we are going to help them. If, again, we also want to understand, is there any countertransference we are experiencing as clinicians? And if this is a good fit for us, and if I feel I'm not going to be a good fit, I'm not going to be an effective therapist. If consultation is not an option because I'm getting triggered myself or vicarious, something is happening, best practice is to refer this person out to who might be a better fit. So there's no one answer there. Yes, if they come, many times we have abusers coming to say, hey, they don't say, oh, I'm abusing. They say, oh, I have anger issues. It's a common presenting concern we see in our clinical practice.
Yes, thank you. The second question is, any recommended places that individuals with F visa or J visa can go and receive therapy in Asian languages? Do you have any resources about that?
I have tons of resources. I am also a board member with National Domestic Violence Agency. So we work with this. We are trying to pull some resources ourselves now. So I recommend one is local county's family law office. They tend to have at least one division which supports victims of domestic violence when they have visa issue. Because I know many times if they are on immigrant visa and not on green card, immigrant visa is sponsored by the spouse, that if they're separating, the spouse withdraws that support, they can go to the county's family law office and they have tons of resources there. That's one place. I start with county, then the state also. State of California's family law website also has resources around that. And Cruz, if I'll hopefully remember to send it to you. If I don't, I'll send me an email. I'll provide these resources to you. Yeah.
Thank you. Yeah.
Another thing I might add is also connecting with local domestic violence agencies. It's all anonymous. Nobody's name is taken. Any information is taken. They also have legal support available. Legal aid is another one. Domestic violence agencies have support available in the languages, in the preferred languages of the victims.
Yeah, and similar to the previous question as well, another person also asked, like, can you point me to any efforts, if any, like that's outreach to abusers to offer help to stop their behavior? Do you also have that?
No, I have not come across. I don't know, Sunita, if you have come across. I have not come across.
So I think what Shilpa is also saying, and I think that's been my experience, either they are court mandated, or because they have been separated, right, and they are working on custody issues, that's when we end up seeing the perpetrator and the victim. And as a family, how do we work through this? But significantly, if I'm honest, we don't see changes because it's just a box that they are ticking so that they can just move along the legal process.
Right. Absolutely. Absolutely. If there is any legal case filed against them, and if we are doing custody evaluation or the victims, the sad, difficult part in the state of California, as far as I know, I'm trying not to get legal here, but it's hard, is the proof of burden lies on the victim.
Okay. Yeah.
So, yeah.
Yeah, for the time that we only have like 1 minute left, and I see there are 4 questions. So the last question that I will let you choose. How about that? You read all the questions in the Q&A and pick one maybe that you want to answer.
Oh, wow. Okay, so there is one on gender we talked about. I've learned that a lot of busy people are also, oh, yeah. Yeah. So someone put the question about experience as also narcissist. Abusive people in experience are also narcissists. Are there different approaches to narcissistic abuse for Asians? There is a researcher in East Coast, Dr. Ramani Darusawala. Cruz, I'll send you the link to that person. I will. I would suggest reading more about that. So when we are talking about narcissistic, remember it's a personality trait. It's hard to change. It's something that's such an automatic thing. So it's hard to change, but I'll put a resource there. So that would be a good place to start with talking about the criteria. Yeah. And then
Okay.
we have last one. I can take, yeah.
Yeah, I just been notified that we have 2 more minutes.
Okay, okay. So do you do presentations for Psy.D programs? I don't know for whom this question is. I don't know. So do you do presentation for Psy.D programs? I really loved your presentation, and I know Sunita and I will be okay to do this presentation, but I don't know if this was for Dr. Cho, but yes, Sunita and I are okay to do this presentation. Yes.
Yeah, and I believe there is a Psy.D program, Asian with I learned a lot of abusive people in my experience are also okay. You cover that. I think there is a question that was asking Dr. Chu if you can talk more about the map. If you, I think I read that question somewhere. Can anyone? Yeah, did you see that, Dr. Cho, as well?
Yeah, I believe I answered that question was like I included Russia in my Asian map, and some of audience are wondering, is Russia Asia? So I answered like in 19th century and early 20th century, many
Okay.
like East Asian, South Asian population moved to the territory to escape from like Japanese and other like a colonialistic like suffering. So currently, I believe like many number of Asian descendants live there. So I meant they are Asians, not only Russians. I'm not like imperialistic some.
Thank you, all 3 of you for your presentation and really like using the time very well, so that we can. I hope that we cover all the questions. But if you have any other questions specific to our presenter, please email us, and then we can also forward our questions to the speakers. So without further ado, I would like to pass the time back to Ellen. Thank you. Thank you.
Thank you. Thank you so much for moderating this, and to all the speakers for spending time with us today and preparing these presentations with so much like rich information about your experience, and like how to support children and like AAAI communities that are affected by domestic violence. So this was really helpful, and everyone in the chat was like really engaged as well. So thank you everyone for being here as well. Just some quick logistics again. We'll be sending out a recording of this of the presentations afterwards. It'll be posted on our website. It'll be included in the email. And then again, if you are here for, if you want to get CE credits and you didn't mark that you needed them in the registration, send us an email at lotusproject@phi.org, and we can get you connected to the CE credits as well. And speaker slides and information will also be provided on the website, so you'll be able to access that within a week when we send out the follow-up email about that. And there will also be an evaluation form. It's really helpful for us to hear from you all what you thought of the presentations, the format, the structure. A lot of the times it's like there's not enough time for the speakers to like talk, but just any feedback from you all is helpful for us. So yeah, thanks everyone for being here. And we'll have the webinar on for another like 2 minutes if anyone has any lingering questions. And yeah, we'll see y'all in the next webinar. Thanks for joining.